Good morning. I want to thank the meeting organizers and Dr. Bujtai for this opportunity to present these very interesting posters today. And I want to thank the poster presenters for sharing their work as well as insight with me in advance. It's not working.
You going to advance the slides?
Yeah. Oh, here are my disclosures. When we look at the genomic landscape of distant metastases from breast cancer and compare it to primary tumors, we find significant concordance. However, novel alterations arise in distant metastases that allow for cell survival and growth. Many of these alterations arise in the setting of drug resistance after primary therapy. In order to improve our long-term outcomes, it's important to better understand these mechanisms of drug resistance. Administration of therapy in the neoadjuvant setting can allow us to do that. Serial tissue analysis can allow us to better understand mechanisms of drug response and resistance. The 4 posters that I will be discussing today look at tissue-based biomarkers to evaluate mechanisms of drug response and resistance. The first 2 posters evaluate aromatase inhibition in estrogen receptor-positive disease. The third poster evaluates dual HER2-targeted therapy in HER2-positive breast cancer. And the final poster evaluates a combination of PARP inhibition and immune checkpoint inhibition. The first 2 posters are sub-studies of a POETIC trial. A POETIC trial enrolled patients with postmenopausal ER-positive primary breast cancer. Patients were randomized to receive 2 weeks of aromatase inhibition or no therapy prior to primary breast surgery. Tissue was collected at baseline and at the time of surgery. Relevant to the posters today, Ki-67 was assessed at both time points. Ki-67 suppression was classified as poor, less than 50%, intermediate, 50 to 75%, and good, greater than 75%. Ki-67 at 2 weeks was classified as high, greater than or equal to 10%, and low, less than 10%. In the study, high Ki-67 after 2 weeks of AI therapy was associated with shorter time to recurrence. So looking at the first poster from Sirvan and colleagues, the authors aim to characterize molecular features predicting AI resistance, as well as relapse in ER-positive, HER2-positive early breast cancers. The authors associated molecular features using RNA profiling with Ki-67 response, as well as time to recurrence. Looking first at intrinsic subtypes, in patients treated with aromatase inhibitor, HER2-enriched intrinsic subtypes showed higher rates of Ki-67 poor response, as well as higher rates of high Ki-67 after 2 weeks, indicating that the HER2-enriched intrinsic subtype was associated with early AI resistance. Next, the authors associated various gene signatures with early AI response and resistance. Looking first at Ki-67 response on the left, we can see that ER signaling and apoptosis signatures were associated with good Ki-67 response. On the other hand, ERBB2, TP53, and homologous recombination deficiency signatures were associated with poor response. Looking at Ki-67 at 2 weeks on the right, we see that immune-related signatures were associated with high Ki-67 at 2 weeks. Next, the authors performed consensus clustering to identify 4 clusters associated with differential Ki-67 response. These clusters are summarized on the right. Cluster 1 was classified by high immune signatures and low ER signaling. Cluster 2, low immune signatures and high ERBB2. Cluster 3, high ESR1 and low PGR. And cluster 4, high endocrine signaling and low ERBB2. Looking first at Ki-67 endpoints on top of the heat map, we can see that cluster 4 was associated with more favorable Ki-67 response. Next, the authors performed multivariable Cox regression to evaluate time to recurrence after adjustment for standard clinic pathological variables. Compared to cluster 1, cluster 2 and cluster 4 were associated with shorter time to recurrence. HER2-enriched intrinsic subtype was also associated with shorter time to recurrence compared to luminal subtypes. The authors conclude that drivers of early AI resistance in estrogen receptor-positive, HER2-positive breast cancer include HER2-enriched subtype, TP53 mutation, homologous recombination deficiency, and immune-related features. They also identify novel molecular subgroups with early AI resistance and increased rates of relapse. These findings suggest potential additional strategies that we can use in the treatment of ER-positive, HER2-positive breast cancer. I want to spend a few moments talking about the HER2-enriched subtype of HER2-positive disease. We know that in HER2-positive disease, HER2-enriched subtype displays better responses to therapy. This is particularly true in hormone receptor-negative disease. But even in hormone receptor-positive disease, we see that the HER2-enriched subtype responds more favorably to HER2-directed therapy. These favorable responses indicate that we can potentially consider de-escalation of our HER2-directed therapy in these patients with HER2-enriched disease. I want to draw your attention to the PER-ELISA study. The PER-ELISA study, like the study presented by Sirvin and colleagues, also enrolled postmenopausal patients with hormone receptor-positive, HER2-positive disease. Patients received 2 weeks of aromatase inhibitor therapy and had Ki-67 assessment after those 2 weeks. Patients with greater than 20% reduction in Ki-67 were classified as molecular responders. Patients with 20% or less reduction in Ki-67 were classified as non-responders. Molecular responders went on to receive a de-escalated neoadjuvant therapy of AI combined with dual HER2-targeted therapy for 5 cycles. On the other hand, non-responders received a more traditional neoadjuvant approach of taxane-based chemotherapy in combination with dual HER2-targeted therapy. It's interesting to note that in the HER2-enriched subtype, like noted by Sirvin and colleagues, we see an increased incidence of non-responders after AI therapy. But in those patients who were HER2-enriched and experienced response to AI therapy, we see that a de-escalated approach of endocrine therapy with dual HER2-targeted therapy actually resulted in a PCR rate of greater than 45%, indicating that if we are able to identify these patients by assessing early response to endocrine therapy and then pursuing a de-escalated approach after subtyping, we may be able to identify a subset of hormone receptor-positive, HER2-positive patients who may be treated with de-escalated therapy. Of course, this requires further validation as this was a small study, but it is an interesting finding. Looking at our next poster presented by Lopez, Knowles, and colleagues, this study also was a sub-study of the POETIC trial. This study aimed to describe the relationship of cut points for estrogen receptor expression by IHC or mRNA with Ki-67 response to short-term endocrine therapy. They also aimed to investigate if these relationships differ according to HER2 and PR status. So looking first at estrogen receptor expression by immunohistochemistry, the authors noted that increasing estrogen receptor expression by IHC was associated with better Ki-67 response. This was overall in the HER2-positive as well as the HER2-negative subgroups. Interestingly, looking at the estrogen receptor levels of less than 1% and 1 to 10%, we see essentially no good responses by Ki-67 in these categories across all 3 groups. Looking at mRNA, again, we see that increasing mRNA expression of estrogen receptor was associated with improved response by Ki-67. And again, at low levels of mRNA expression, we see essentially no good responders by Ki-67. So the authors conclude that there was a similar separation of poor responders from intermediate and good responders by IHC and mRNA. There was little endocrine responsiveness at IHC less than 10%, and there was no distinction in endocrine responsiveness between estrogen receptor less than 1% and 1 to 10%, irrespective of HER2 status. In tumors with low estrogen receptor, we know that the expression of estrogen has low predictive and prognostic value. It is often debated how these tumors should be classified. The most recent ASCO-CAP guidelines classify these tumors as low estrogen receptor positive tumors. Looking at response to neoadjuvant chemotherapy in 2 institutional cohorts here, looking on the left at PCR, we see similar rates of PCR in ER-negative and low ER-positive disease. And on the right at long-term outcomes, again, after neoadjuvant therapy, we see similar outcomes in ER-negative and low ER-positive disease, indicating that in clinical trials of chemotherapy, it is reasonable to group low ER-positive disease with ER-negative disease. However, when we look molecularly, we do see some distinct features between low ER-positive and ER-negative disease. On the left shown is intrinsic subtyping by subtype. And we can see that in triple-negative breast cancer, shown by the yellow plus signs, we see a clustering in the basal-like intrinsic subtype. However, in low ER-positive disease, shown by red plus signs, we see that these tumors kind of span across all intrinsic subtypes. And so we can see at a molecular level, there is really a distinction between these two groups. I also want to highlight the P024 study from Matt Ellis's group looking at neoadjuvant endocrine therapy. In this study, even at low all red scores, we did see endocrine responsiveness, particularly with AI therapy, indicating again that these two sets, low ER positive and ER negative tumors, are really distinct biologies. That brings us to the third poster from the Netherlands Cancer Institute, presented by Van der Voort and colleagues. The objective of this poster was to evaluate blueprint subtype as a biomarker for response to trastuzumab-based neoadjuvant chemotherapy with or without pertuzumab. Blueprint is an AZ gene molecular assay that classifies breast cancer into functional subtypes, including HER2, luminal, and basal. This study enrolled patients with stage 2 to 3 breast cancer treated in the Netherlands with neoadjuvant trastuzumab-based therapy. Pertuzumab was administered in about half of patients, and blueprint subtyping was conducted on pretreatment biopsy. Here are the baseline patient characteristics. We can see that they were generally well-balanced between the no pertuzumab and pertuzumab group. However, there was a slightly higher number of node-positive and grade 3 patients in the no pertuzumab patients. Looking at blueprint subtypes, we see that the majority of the tumors were classified as HER2 type. Some were classified as luminal. When dual typing was allowed, this is a single tumor can sometimes be classified into 2 functional types. We see that some of them were reclassified into luminal HER2. Looking at outcomes, as has been previously reported, pertuzumab did result in improved rates of PCR. However, greater benefit was seen in the single HER2 blueprint subtype compared to other blueprint subtypes. Looking at long-term outcomes, survival was statistically significantly improved with the addition of pertuzumab in the single HER2 subtype. However, when other blueprint subtypes were included, that statistical significance was lost. Looking at conclusions, the benefit of pertuzumab was greatest in patients with a molecularly defined HER2 activated subtype. Similar findings were seen in the molecular analysis of the affinity study. The authors conclude that patients with single HER2 subtype identified by blueprint could be optimal candidates for chemotherapy de-escalation. This is a finding that we have seen with other HER2 signatures as well. We have seen that intrinsic HER2-enriched subtype has been extensively associated with PCR across many neoadjuvant studies. Recently, Pratt and colleagues reported that when HER2-enriched subtype was combined with high levels of ERBB2 expression, this lended itself to selecting a group of patients that were exquisitely sensitive to HER2-directed therapy. Looking below at the results of the PAMELA study, we see that combining HER2-enriched intrinsic subtype with high levels of ERBB2 mRNA expression identified a group of patients who had a PCR rate of approaching 45% with dual HER2-targeted therapy alone, suggesting that this combination biomarker could really select patients with sensitivity to HER2-directed therapy and de-escalated approach. I also want to highlight the WSG ADAPT study. This was a study that looked at de-escalated therapy in patients with HER2-positive, hormone receptor-negative early breast cancer. In this study, with dual HER2-targeted therapy alone, we saw PCR rates approaching 35%. And with taxane chemotherapy in combination with dual HER2-targeted therapy, PCR was greater than 90%. The study authors did associate RNA signatures with favorable response, and looking particularly at that neoadjuvant chemotherapy-free group, it is interesting to note that along with HER2 signatures, immune-related signatures really predicted for PCR benefit. It is interesting to think that if we really think about de-escalated approach in these HER2-enriched tumors, perhaps the addition of immune therapy may improve our outcomes. And in fact, the WSG group is exploring a study of immune checkpoint inhibition in combination with dual HER2-targeted therapy in HER2-enriched HER2-positive early breast cancer, the KEYRICH-01 study. This brings me to our final abstract presented by Im and colleagues. This was a window of opportunity study evaluating neoadjuvant olaparib and durvalumab in triple-negative and low ER-positive breast cancer. The primary objective was to assess treatment-induced change in tumor biology using serial biopsy. Secondary objectives included efficacy and safety endpoints. Patients with stage 2 to 3 breast cancer were enrolled in Korea. Patients were treated with neoadjuvant olaparib for 28 days. On day 15, durvalumab was administered. Following olaparib therapy, all patients received standard neoadjuvant chemotherapy with anthracycline and taxane, followed by surgery. Serial tissue collection was conducted at baseline, day 14 after olaparib monotherapy, and day 29 after olaparib in combination with durvalumab, as well as at the time of surgery. Serial imaging was also conducted. Here are the patient characteristics. It's important to note that approximately 30% of patients had BRCA1/2 mutations, and 50% of patients were homologous recombination deficient. Looking at response, we saw a high rate of PCR in the study, 72%, and in patients with germline BRCA1/2 mutations, the PCR rate was even higher, 86%. Looking at PCR between homologous recombination deficient versus proficient tumors, we did not see statistical significance. The authors evaluated early metabolic response to olaparib and noted that after 2 weeks of olaparib therapy, homologous recombination deficient tumors had early metabolic response compared to proficient tumors. However, after 4 weeks of olaparib therapy in combination with durvalumab, that metabolic response seemed to normalize. The authors conclude that olaparib and durvalumab, followed by standard neoadjuvant chemotherapy, result in very high rates of PCR. Functional HR status, measured by Rad51 foci formation after irradiation, was predictive of early metabolic response, and genomic and transcriptomic analyses are currently underway on serial biopsies. This brings us to important questions about PARP and immune checkpoint inhibition in the clinic. Mechanistically, there are several potential mechanisms of synergy between these two classes of agents. PARP inhibition results in DNA instability, generating neoantigens. This results in cytosolic DNA release, activating the CGAS-STINK pathway, which results in interferon activation as well as PD-L1 upregulation. Preclinically, synergy has been demonstrated. Clinically, however, we have limited data on the synergy between these two classes of agents. 2 studies have reported on PARP inhibition in combination with immune checkpoint inhibition, but both of these studies lacked a PARP inhibitor monotherapy arm, limiting the assessment of synergy between these two classes of agents. Studies such as that conducted by Aim and colleagues with serial biopsies following olaparib monotherapy and then IO in combination with olaparib can allow us to better understand the synergy between these two classes of agents. Another important question that this study raises is in those patients who do respond very well to PARP plus or minus IO therapy, do we need additional neoadjuvant chemotherapy? I want to highlight the NeoTALA study presented at ASCO this year by Jennifer Litton. The study evaluated neoadjuvant talazoparib in germline BRCA mutant patients. Patients received 6 months of talazoparib monotherapy. The study reported a PCR rate of 45.8% in 48 evaluable triple-negative breast cancer patients. And again, the question arises, in these patients who are very sensitive to PARP monotherapy, do we need additional chemotherapy? It is interesting to note that on this study, approximately 16% of patients progressed to primary PARP inhibition. And it is interesting to think about why these patients with germline BRCA mutations may be resistant to primary PARP therapy. And again, studies like that designed by Aim and colleagues can help us understand these questions at the biomarker level. So in summary, there is increasing importance of tissue sampling before, on, and after neoadjuvant therapy. Gene expression assays, as well as other biomarkers, can identify pathways of response and resistance. Rational biomarker-driven studies can allow us to design de-escalation approaches, and on the other hand, residual disease can help us to identify potential targets for additional therapy to prevent recurrence. Thank you.
Thank you, Dr. Basho, for the discussion. So we have a few minutes for a question and answer. I think all of our poster presenters are joining us virtually, so I would like to ask the team to bring them in. So we received a question online, which is, was the HER2-enriched subtype enriched in certain other immune cell markers, and was there any immune deconvolution analysis performed to further characterize the immune-related features of the HER2-enriched subtype? So this is a question for Dr. Servan.
Hello? Can you hear me? Yes. So, we found an association of high expression of some immune-enriched related signatures and single genes, and also some immune checkpoint component related signatures with the A2 enriched subtype. But there is ongoing work looking at multiple immunophenotyping on the most informative samples from this study, and we are also planning to do some digital spatial profiling to characterize deeper these immune-related features.
That's great, thank you. I also have a question relating to the HER2-enriched subtype. So clearly, there is more and more data that suggests that they have some unique clinical features that render them highly sensitive to HER2 therapies, less sensitive to endocrine therapy. So how do you implement this knowledge in the clinic, Dr. Basho? Or how do we act on it?
Yeah, that's a really important question. I think it's particularly relevant to hormone receptor negative disease, where we have seen exquisite sensitivity now in several trials to HER2-directed therapy and potential considerations for de-escalated approaches. I think certainly we can think about shortening our duration of neoadjuvant chemotherapy and perhaps limiting it to single-agent chemotherapy, THP type approach, rather than a TCHP approach in these patients based on the WSG ADAPT and DAPHNE studies. But the question is really in HR-positive disease, where we see less endocrine sensitivity as well as lower rates of PCR. And I think we certainly need to think about how to best treat these patients. I think one question that has started to come up is, can CDK inhibitors assist in overcoming some of that endocrine resistance in the HR-positive patients? And there was recently a paper published in Nature Communications showing that in HER2-enriched hormone receptor-positive HER2-positive disease, treating with dual HER2 blockade actually induced a luminal A phenotype that was sensitive to CDK inhibition. And I think we certainly need studies that are currently ongoing to report out on adding CDK inhibitors in this space, but interesting to consider.
Dr. Im, I also have a question for you about what do you plan to do next? Because the pathological complete response rates that you reported in your small study is really the highest that have ever been reported, like 73% pathological complete response.
Yes, thank you very much for the question. Actually, that high PCR rate was higher than we expected. And we also compared the PCR rate from similar cohort who did not receive olaparib durvalumab before, and the response PCR rate was 38%. So it might be a rationale to think about chemotherapy-free neoadjuvant olaparib plus durvalumab for 4 to 6 months. If the patient get PCR, we might save the patient from the chemotherapy. But we are currently doing the gene expression profiling to understand who are the right patient population, because we already have a IO plus chemo combination neoadjuvant trial result, and which is also changing our practice.
That's great. So you kind of adopting a strategy that the I-SPY trial is pioneering in the United States, right? That you use the patient's response to guide subsequent therapy before surgery. Any other questions from the audience? Or? So then we're probably going to finish on time. So I would like to thank you for attending this session, and like to remind you that the general session will start at 8:45. So please join us in the next sessions and visit the exhibits. Thank you.